Dear residents, in case you thought, oh, this is just a workup class, history, physical examination, biopsy, CT scan, I know this already. 20 minutes later, you will realize you didn't know enough and with clarity. Workup for a cancer is not just a checklist. Workup for a cancer is a strategy. I see residents answering often, sir, I will take a biopsy from the most dangerous looking area of the growth and it destroys the margin for the surgeon. I see resident answering often, sir, I will order a CT scan, but he misses the nerve involvement despite patient told him his chin was having numbness since 2 months. I see residents often answering, sir, I will perform this resection, that resection, reconstruction, sentinel node biopsy, neck dissection, IMRT, chemo, immuno, but he didn't do chest imaging to rule out lung metastasis. See, a bad surgery can be fixed. A bad radiation plan can be replanned, but a bad workup is permanent. If you get wrong information from your workup, you will end up doing a wrong treatment. So today, we are going to burn this checklist. We are going to see how a detailed workup is to be done when you see a patient who comes to you with a non-healing ulcer or a growth over his tongue or cheek. I am not going to teach you only NCCN protocol, but more importantly, I am going to teach you the logic behind these protocols. I am Dr. Parveen Ahlawat. Welcome to Oncology for Residents. Let's get to work. Workup is not just about diagnosing cancer. Workup is about assessing the patient as a whole. If you miss the dental evaluation in your workup, you cause osteoid necrosis. If you miss the nutritional assessment in your workup, your patient fail treatment due to toxicities. So I'm going to take you through step workup you need to write in theory and say in practical exams when you get a patient with oral ulcers suspicious for carcinoma. This is exactly how you should answer in your exams and exactly what you must do in your clinical practice. First, history and physical examination. I am not going to teach you how to take history, you know that. But for oral cancer, I want you to quantify the risk factors. Do not just write he's a smoker. Write pack years. Do not just write he's a drinker. Find out whether he is a light drinker, moderate drinker or heavy drinker. And you know how to find it out if you have watched my previous lecture on etiology of oral cancer. Next, the physical examination. You need to do a complete head and neck examination even if the patient has only one small ulcer over its tip of the tongue. I am not going to tell you how to take history and do physical examination. We will surely do that when we do case presentation on our YouTube channel sometime later. But I just want to emphasize a very important thing resident often make mistake in. It is mirror examination, also called as indirect laryngoscopy. Indirect laryngoscopy, IDL. IDL is a simple zero-cost bedside OPD procedure. You should be expert in doing it. Do it regularly, again and again on cooperative patient. You can even do it on your friend in practice. Some people have a special endoscope called Hopkins rigid 70-degree endoscope. It is again a simple zero-cost bedside OPD procedure. This is an excellent tool to visualize pharynx and larynx if you have it in your OPD. Residents are often confused whether they should say fiber optic laryngoscopy, also called as direct laryngoscopy, routinely in their exam when they get oral cancer. Remember, fiber optic laryngoscopy is not an OPD procedure. It is generally done in minor OT and involves a separate cost. Hence, you need to select those cases who may indeed require it. See, in an ideal scenario, direct laryngoscopy should be done for every patient with oral cancer. But in real world scenario, it is done in specific scenario only. So which are those specific scenarios? Number one, when you are not able to find the posterior most extent of tumor on physical examination and unable to do indirect laryngoscopy. For example, when there is an extensive oral tongue lesion going into base of tongue and your finger do not reach posterior most extent, you need to do fiber optic laryngoscopy to see the exact posterior extent. If you have a retromolar trigon lesion and it is going posteriorly into tonsillar fossa, you need to do DL-scopy to see the inferior most extent of tumor. Second scenario where you will do direct laryngoscopy is when you suspect field cancerization. Field cancerization. When do you suspect it? When a patient is heavy smoker and heavy drinker, where you want to look at his oropharynx, larynx and hypopharynx to see if he has any other lesion due to field cancerization. The third scenario where you will do direct laryngoscopy is when you have symptoms suggestive of another synchronous lesion in the oropharynx, larynx or hypopharynx. You should do this procedure. For example, a patient with buccal mucosa carcinoma also says he has hoarseness of voice. In this case, you would want to look at his larynx to see if there is another lesion to explain his hoarseness. Basically, fiber optic laryngoscopy is done in a case of oral cancer patient is to most often look for synchronous primary. Remember, field cancerization does not exist only in textbooks. It is real. Next, tissue biopsy. Tissue is the issue. Do not assume all non-healing ulcer in oral cavity are squamous cell carcinoma. Around 5% of time, you get surprises. And those surprises will change your treatment and prognosis drastically. Dear residents, listen very carefully what I am going to tell you now. We cannot treat any patient on the line of cancer without having had proved that it is a malignancy. Before you subject a patient to cancer-directed treatment, you must establish that you are treating a cancer. And for that, you need histology of that biopsy, histology of that lesion. It is a medical legal requirement to get histological proof of malignancy before you treat him with any cancer treatment modality. Now let's talk about the biopsy. This is where many of you get confused in the exams. The examiner asks, "Doctor, how will you take a biopsy for this oral ulcer?" And I hear residents throwing out random terms. Excisional biopsy, true cut biopsy, punch biopsy, incisional biopsy. You are just guessing. And if you guess wrong here, you don't just fail in the exam, you ruin the patient's surgery before it even begins. So let us clear this once and for all. Can you do an excisional biopsy for suspicious looking malignant oral ulcer in tongue or buccal mucosa? Never. And I repeat, never do an excisional biopsy for a clinically suspicious cancer unless it is very small and benign looking and you can get clear margins all around. Doing excisional biopsy is almost like committing a crime. Why? Because if you cut through the tumor, you destroy the margins for the definitive oncological surgery to be done later. You ruin the case before it even starts. If you see a suspicious ulcer, specifically a T1 or T2 lesion, and you do an excisional biopsy, you have committed a blunder mistake. You have removed the visible tumor, but you have not taken the wide margins required for an oncological safe surgery. Now, when the surgeon goes in for the definitive resection, he cannot see the tumor edges. He doesn't know where to measure his 1 centimeter margin from. He is flying blind. So, for a clinically suspicious malignancy, excisional biopsy is contraindicated. Do not say it in exam. What about true cut, also called as core needle biopsy? Some of you love saying word true cut. Listen carefully. You do not use a true cut needle for a surface ulcer in the mouth. This is useless. True cut is for deep masses, deep swellings. It is for neck node. It is for a sarcoma buried deep in the muscle. It is for a breast lump, but it is not for surface ulcer of oral cavity. So what is the correct answer then? For a mucosal lesion in tongue, buccal mucosa, the answer is punch biopsy. Punch biopsy. Punch biopsy is elegant. It takes a precise round core of tissue. It gives the pathologist the full depth of mucosa. It is easy, it is fast, and it creates minimal artifacts. There is another type of biopsy we sometimes do in oral cavity is incisional biopsy. Incisional biopsy, this used to be classic. You take a wedge of the tumor. This technique is almost rare to perform these days. So in most of the cases, when an examiner asks you, how will you take a biopsy for this oral ulcer? Your answer should be punch biopsy. You will be correct in most of the scenario. Now, I want you to understand a technical but very important exam question with regard to biopsy. Examiners always ask, where do you take biopsy from? I see residents answering many a times wrong. They think they should go for the central, deepest, nastiest looking crater in the middle. This is a mistake. The center of a large tumor is graveyard. It is hypoxic. It is necrotic. It is just a dead tissue and debris. If you take a biopsy from there and send that to pathologist will report necrotic debris, no visible tumor cell seen, and you look dumb and foolish. Listen carefully. You must biopsy the most representative area of the tumor, avoiding necrotic area. Generally it is the edge of the tumor. The edge or the periphery is where the action is. This is where the proliferating malignant cells are. This is where the tumor is alive and invading. There is often another reason residents often say when they are asked why from the edge of the tumor. They often say, sir, I will do biopsy from the edge, taking both tumor region and adjacent normal tissue. So the pathologist can compare malignant cells from normal adjacent cells. These days, it is no longer a correct answer. This used to be a reason many years ago. But now pathologists are too good these days and do not need any normal adjacent cells for comparison. Remember, this reason of taking biopsy from the edge is applicable if you have a non-healing chronic ulcer which looks tuberculosis or syphilis, where you have to have normal adjacent mucosa. But if you have a malignant looking oral ulcer, the reason of taking biopsy from the edge is to pick up most proliferating malignant cells rather picking dead necrotic tissue. So the rule is simple. Stay on the edge, avoid the dead center. Okay, will you please remember that? Now, I want to ask you a question. What will you do if the patient has a palpable suspicious neck node beside a primary tumor in oral cavity. What will you do if the patient has a palpable neck node besides a primary tumor? If we have already confirmed squamous cell carcinoma from the primary, should I now do FNAC from the node also? The answer is no. Let us have a real world conversation on this. Let me teach you the high probability logic that allows us to skip the FNAC. Imagine this scenario. You have a primary tumor in the tongue. Biopsy from this tongue is squamous cell carcinoma. You also have a neck node, level 2 node, which is 2 to 3 centimeter, firm or hard, and shows typical features of malignant node on CT scan. Ask yourself, what is the statistical probability that this node is tuberculosis? See, you already have a biopsy proven tongue cancer. What is the probability that this node is tuberculosis? Almost zero. What is the probability it is lymphoma? Extremely low. The probability that this is a metastatic squamous cell carcinoma is close to 100%. So in this common scenario where you already have a proof of malignancy from the primary, doing an FNAC from the node is a waste of time. It delays surgery by few days. The waste of money. FNAC has a cost. So if the primary is proven and the neck is radiologically compatible with neck node, malignant neck node, you should not do FNAC from the node. We proceed directly to neck dissection. We treat the neck along with the primary. Now the next thing in workup comes imaging. Usually in a standard lecture, I would rattle off a list of imaging here. Do a CT scan for this, do an MRI for this, but I'm not going to do that today. Why? Because imaging for oral cancer is a big topic. Also, imaging of oral cancer is the most misunderstood topic in residency. Residents often get trapped in it. There are some residents who are bone lovers who only order CT scan irrespective of primary. There are residents who are soft tissue lovers who only order MRI irrespective of primary. And there are residents who say a diplomatic answer, sir, it depends. If you get the imaging wrong, you either miss the nerve spread or you cut the patient jaw unnecessarily. This topic is too critical and important to cover in this video. So I have decided to dedicate an entire separate video just for imaging for oral cancer. In that video, I will show you why the MRI is a drama queen. Why the CT is sometimes blind. And exactly when to trust which scan. It is a must-watch video. Do not miss it. For today, for your workup list, just write this down. For local extent of tumor, most of the time we will do contrast enhanced MRI for tongue, floor of mouth, primary, and if you are suspecting perineural invasion. We will do CCT neck for well lateralized primary sites like buccal mucosa, gingiva, RMT. For systemic extent of disease, we will do CT thorax. We do PET CT in some special scenario. We will talk about that in that video. Okay guys, let's talk about a workup procedure that is slowly disappearing from our clinical practice. Yes. Examination under anesthesia. Examination under anesthesia, EUA. When we say examination under anesthesia, what exactly do we want to do under anesthesia? We want to do a good palpation of the oral cavity and oropharynx when the patient is relaxed, his muscles are relaxed. This is one thing we will do under EUA. The second thing we want to do is triple endoscopy. Triple endoscopy. You do 3 endoscopies in same sitting of anesthesia. It is also called a pan endoscopy. So which are those endoscopy? Number 1, direct laryngoscopy. To find out the posterior most extent of oral ulcer if your finger cannot reach there. And to check oropharynx, larynx and hypopharynx. Second endoscopy is esophagoscopy. Esophagoscopy to rule out synchronous esophageal cancer. The third endoscopy is bronchoscopy. This is to rule out synchronous lung cancer in the bronchial tree. When a resident is asked, when do you do an EUA? He usually looks confused. He thinks EUA is there in the guideline for most workup for oral cancer, but I have hardly seen it being done for oral cancer. So why so? See, to an extent, you are right. No one does this procedure these days. I never do it. In the last 20 years, examination under anesthesia has gone from routine to rare. Why? Because, listen very carefully. Because today we have good imaging modalities such as CCT, MRI to look inside the throat. Because today we have good flexible endoscope which can look deep inside the throat. Because we have good imaging tool to look for synchronous primary in upper aerodigestive tract and lungs such as CT thorax and PET CT. So my advice regarding EAU is in exam, do not say EUA unless you are asked about it. Let us assume your examiner ultimately asks you, will you do EAU for your patient? What should you do? How will you handle this difficult question? Listen, examiner actually wants to know, have you understood the concept? Examination under anesthesia is in guideline. Remember, I showed you NCCN checklist for workup for oral cancer. EUA is there in that list. And it is not like optional or maybe or consider it. NCCN say just do it. How will you handle this situation? If you answer, sir, EUA is obsolete now, you might be in trouble. Here you need to play a little diplomatic. There are very specific clinical scenarios where you may consider EAU, and these scenarios are rare. So write this down. There are only two indications where you may have to take patient to OT for an examination under anesthesia. First, trismus. This is the most common practical reason for doing EAU. If the patient has severe pain or pterygoid spasm, they cannot open his mouth in the OPD setting. You cannot see the tumor. You cannot biopsy it. You cannot assess the posterior extent of tumor. MRI is not enough. You need to physically see the lesion to plan the incision or radiation. Anesthesia breaks that spasm and gives you an access. Under anesthesia, you can palpate lesion easily. Second indication is to search for synchronous primaries. If your patient is a heavy smoker and drinker, he may have field cancerization. He is at high risk of a second cancer in the esophagus or lung. Most guidelines specifically mention EAU with pan endoscopy, direct laryngoscopy, esophagoscopy and bronchoscopy when clinically indicated. If the patient has dysphagia or hoarseness, You need to look down there yourself. Now a reality check. In the old days, to see the larynx and subglottis, you needed a rigid scope with a paralyzed patient. In old days, to see the larynx and or subglottis, you needed a rigid laryngoscope with a paralyzed patient. Today, we have high definition, flexible fiber optics endoscopes in almost all hospitals. With this, now you can visualize the entire pharynx and larynx in just 2 minutes while the patient is sitting in chair without anesthesia or even sedation. You can rule out a second primary in the lung with a CT thorax. So the pan endoscopy indication has largely been replaced by good imaging plus flexible endoscopes we have today. In modern practice, we often replace pan endoscopy with these imaging and a flexible fiber optic scope. CT thorax and flexible fiber optic scopy almost does as good work as pan endoscopy. It saves OT time. It saves anesthesia risk. So the bottom line is, do not do EUA for every patient. This is a waste of resources. Taking a patient to OT for EUA requires anesthetic clearance, OT slot, pre-op investigation, and anesthesia risk. If I can get 95% of information from an CT, MRI, and an OPD exam, I cannot justify the cost and risk of general anesthesia for the remaining 5%. See, we save the OT for surgery, not for diagnosis. To be on safer side, do not say EUA from your side. Let examiner ask you, and this is how you should handle it. Remember, EUA is there in the guidelines, but no one does it. Now pay attention. This is where residents fail. You get the scan, you get the biopsy, you get the endoscopes, and you think you're done. You're not done. Remember, cancer management requires multidisciplinary team. Multidisciplinary team. If you don't involve multidisciplinary team now, you are just managing the tumor, not the patient. So which are those multidisciplinary team? Number 1, dental surgeon. For dental evaluation. Dental evaluation is mandatory. This is not for cosmetic. If we are planning radiation, we need to extract hopeless teeth at least 2 weeks before we start radiation. If you radiate a bad tooth now and pull it later, you get osteoradial necrosis, sometime which is disaster. Second team is team involved with nutrition, speech and swallowing. For a locally advanced tumor or anyone with significant weight loss, we need a baseline swallowing assessment. We need to decide now whether the patient requires any assisted feeding in the form of nasogastric tube or prophylactic PEG tube. Do not wait for patient to starve during radiation. Third team is the psychological counselor for smoking cessation. This is very important. Continuing to smoke during radiation or cancer treatment increases not only toxicity but also lowers the cure rate. So counsel them. The fourth team is team which involves for fertility preservation. Fertility preservation. For our younger patients, if they are going to receive chemotherapy, you must discuss sperm banking or fertility options before you start chemotherapy. So let us summarize the ideal workup. History, physical examination, biopsy, imaging, supporting multidisciplinary team including dental, nutrition, speech, smoking cessation. Once you have all this information, you present the case or your patient in the multidisciplinary tumor board for the best treatment for this patient. This is the gold standard approach. In next video, we will dive deep into the imaging protocol for oral cancer. Brace yourself. Stay tuned.